Hello, and welcome to Colorado Dental Assisting School. We are going to be reviewing week 2. Our lecture for week 2 goes over forehanded dentistry, coronal polishing, pain control, and of course, front office and interviewing. All right, let's talk about how we can get ready for our patients. So before you seat your patient, you want to make sure that you've reviewed the health history for that patient, the treatment we're doing for the day. So take a look at your schedule beforehand. You want to set up all of your instruments that you'll need for treatment. Make sure you have everything you need for your doctor as well. You want to seat the patient, go ahead and place their bib immediately and give them their PPE. That way they have everything they need. The first question should be their recent health history. Obviously, you've talked to them, you've identified your patient and discussed the treatment that they're having for the day, but you want to review health history right away. If we don't have a new health history scanned into the chart, we want to go ahead and get that updated and ask them, has there been any changes to your health history recently? Any new medications, any hospitalizations that we need to know about? Even if you saw them the day before, right, even before you closed, you don't know what might have happened that night. So please ask them the same question about their health history every time you see them, and make sure you put it in your chart notes that you have updated it. And again, we want to review treatment for that day, explain to them what's going on. So for example, if we're doing a crown, we want to explain to them that today we are prepping for the crown. So that means they will get a temporary crown before they leave. You want to give them post-op instructions for that treatment and let them know when the permanent crown will be back. Every lab is a little different. Some of them will take 2 weeks, some of them can take 4 to 5 days. So make sure the patient understands when the permanent crown will be back, and that you will either call them and let them know when to come in, or you can go ahead and schedule them that day. You want to give yourself a little extra time though. If it's coming by mail, I usually would schedule 1 to 2 extra days, as opposed to, let's say, if it was coming in 2 weeks, I would do 2 weeks and 2 days, just to make sure we have it. And then your job as a dental assistant is to make sure that those lab cases are in and ready to go before your patient comes in for their treatment, or before that day even. So on Friday before the following week, you want to make sure all of your lab cases are either on their way and will be here in time, or have already arrived. If it doesn't, which sometimes things happen, that's understandable, please call your patient and let them know before their appointment. You don't want them to be sitting in the waiting room and you have to go out there and explain to them that you do not have whatever treatment it is that we have going on, whether it be a denture, a partial, a crown, a bridge. We don't want to have to tell them same day. They might have taken time off of work. They might have had to call a babysitter. So please be very considerate of your patient's time, as well as the doctors and yourself, because we don't want a big gap in our schedule for the day. The next thing you need to do is make sure you have your own PPE as well as your patients, and that you guys are set up and ready to go. This is an example of what a tub and tray system looks like. So it's showing you all of the instruments and materials we could possibly need for the treatment that's being done that day. One thing I suggest to all of our new graduates is that you guys carry a small tablet that will fit into your lab coat, so you can write down what the doctor likes to use. You might have a doctor that uses a certain type of anesthetic, or maybe a certain size needle for all of their injections. You want to make sure that you're set up and ready to go. That way you don't have to jump up and down out of the seat constantly while we're trying to complete treatment. It will, take a little longer if you're distracted and having to leave the room if you're not ready to go. Let's talk about pain control in dentistry. This is important. This is one thing that can cause most of our patients to have anxiety. A lot of times, the scariest part for them is having to get an injection in their mouth, which is the local anesthetic that our doctor gives to numb them. So it's important that we do our jobs as dental assistants and give them a pre-numbing gel, which is called a topical anesthetic. So what you're looking at here is a jar of hurricane topical anesthetic. Some of them come in jars like this, and it's a gel type of topical anesthetic. Some of them come in a tube or a little syringe. It just depends on how you order it. So I don't want you to get too hung up on how this looks because depending on how we order it, it could come in a spray. It just depends on what the doctor likes. Your job as the dental assistant, though, is to make sure we are set up with our aspirating syringe, our anesthetic, and of course, the topical anesthetic. So this is an example of the anesthetic setup. Whenever I get this ready, I do not open the clean needle until the patient is seated. You really don't want to start opening things that you can't put back if the patient doesn't arrive. Let's say it's the last patient of the day. We don't want all of our instruments and materials to sit out while our cleaning crew comes in either. Once you do get this set up, one thing I would suggest is covering your instruments and your anesthetic setup with the patient napkin or the patient bib. That way when they come in, if they are high anxiety, they don't immediately see that and start to get, a little short of breath and maybe kind of freak out a little. We don't want them to feel any more nervous than they already do. So I like to cover all those instruments because they don't understand exactly what they're used for, and some of them are a little intimidating. So what you're looking at here is our cotton tip applicator, which is what we're going to use to place the topical anesthetic. We have a couple 2x2s of gauze. We like to call them 2x2s because whenever we use the term gauze, our patients think that they're bleeding. So try not to use that term too often when you're talking with the doctor in front of the patient. This one shows our topical anesthetic in a tube here. So what you'll do is put some onto your cotton tip applicator. You're going to use the 2x2 to dry the oral mucosa. I like to place the topical with the cotton tip applicator and put the 2x2 over it and have the patient bite down. It's going to stay in the mouth for anywhere from 3 to 5 minutes. That way we have completely numbed that area. So that way when the doctor goes in to do an injection, it's not a really big pinch and it doesn't make them, tighten up around the needle and possibly cause them to bruise or get a hematoma. We don't want that to happen. Once you have placed a topical anesthetic, you can go ahead and load your syringe. We do have a video on our student portal that you can watch on how to load a syringe and unload a syringe, and also how to correctly recap a needle according to our OSHA guidelines for safety. What you see at the bottom of this slide here talks about certain types of injections. So the short needle is usually used for maxillary, and it can also be used for mandibular teeth. We have a long needle for a mandibular IA block, and we also have a really short needle called our PDL needle is what we call it. It can also be called an extra short, but the PDL is short for periodontal ligament injection, and we do have that on another slide here that we talk about as well. One thing you want to remember about these anesthetic carpules is that they do have an expiration date on them. So when you guys are restocking your rooms, make sure that you rotate them out. You don't want to continue to put the new ones on top and have them expire. The needles have expiration dates as well, so please pay attention to your materials when you're restocking the room. This is our slide that talks about injections. So you have 3 different examples here. One thing I want you to remember from this is these don't all come in these colors. We could order them all in blue, all red, all yellow. It just depends on how we order them. So I don't want you to think, oh, the PDL needle is always going to be blue. We have some that are purple. It just depends on how we order them. This is just an example. So this talks about the IA nerve block on the mandible. IA stands for inferior alveolar nerve block. The reason we do that is because it will numb an entire quadrant of teeth. So the whole right side all the way to the midline on the mandible, which is your lower jaw, will be numb. The tissue, the lip, the teeth, including half of the tongue. And we'll usually either do a right or a left IA nerve block. It's not too common that we do both when the patient is awake because they can't feel their tongue and it can kind of scare people. We will do it if we're doing oral surgery. So that is a pretty common example of a time when we would block on both sides. Another injection on the mandible that we can do would be a mental block. And I apologize, guys. When I say we, I mean the dentist. We do not give injections. Let me correct myself. Please don't try to give anyone injections. You will not be learning how to do that in this course. So the dentist will be giving a mental block on the mandible. When they do that, If you remember in week 1, we had a blown up picture of the mandibular jaw, and it showed the condyles, the ramus, and the mental foramen. The mental foramen is on the right and left side of the mandible, and it's right behind the canine where the first premolar is. When you guys go to place your topical anesthetic, you're going to pull the patient's lip out, and you will look for a tissue attachment there. That's where you're going to dry the oral mucosa and place your topical anesthetic to numb. That mental block will take care of just the anterior quadrant of the mandible. The tongue will not be numb. It will only be from the canine to the midline of the body, or sorry, of the jaw. So it's either the right or the left side. The nice thing about the mental block is their tongue isn't numb. So let's say they're on lunch break and they're coming in to get a filling really quick or have some sort of procedure done. It's always nice if we can do that on the anterior instead of giving them an IA nerve block and then their whole tongue or half of their tongue being numb for a long time. Another injection for our short needle would be on the maxillary, and this is called infiltration. On the maxillary, our nerves are a little different. We don't have a big nerve running and feeding all of them at once like we do on the lower. We have branches of nerves feeding into all of the maxillary teeth. And if you go back again to week 1, you can see those blown up pictures of the anatomy, or you can look in your textbook. Infiltration is going to numb anywhere from 1 to 2 teeth, depending on where the doctor infiltrates. So please remember to ask questions. Do not assume you know where they want you to place the topical. They might even do an infiltration block where they come out a little further onto the cheek and hit 3 or 4 teeth. So ask your doctor, don't be afraid, and let them know, hey, is this a good placement? Because last thing you want to do is put topical in someone's mouth and it not be in the correct position. That stuff doesn't taste very good. It's not that much fun. So if we're going to do it, let's do it correctly. The fourth injection down here is a palatal maxillary. So on the palate, we would use a short needle. Now, this is not as commonly done unless we're doing oral surgery or if for some reason a patient's having really bad pain or sensitivity on the palate side. A lot of times infiltration will be enough for us to go ahead and crown prep a tooth or get it ready for a filling on the maxillary. But if we're doing an extraction, we want the tooth to be numb all the way around. And when we infiltrate, it only numbs the buccal side or the facial side of the gingiva. On the palatal side of the gingiva on the maxillary, it will not be numb. So keep that in mind when you're suctioning. Anytime you're suctioning on the maxillary, if you're working for a right-handed dentist, it'll be on the upper right. If you're working for a left-handed, it'll be on the upper left of the palate. Keep it in mind that they are not numb on that area. Not that I ever want you to rest your suction anywhere in their mouth other than on a cotton roll, but if you scrape them accidentally, they will feel it. The last injection down here at the bottom is called your PDL injection, and every tooth has a periodontal ligament. So let's say we have a tooth that is having a hard time getting numb. A lot of times we'll call them a hot tooth. The patient comes in, they have an infection, and giving them an infiltration just didn't do it. The rest, the tissue, everything is nice and numb, but when we go in to prep the tooth, the patient is still in a lot of pain. So what the doctor can do is give a PDL injection. They can either go into the sulcus of the tooth, which is where the gingiva meets the tooth, or they can go straight into the nerve if the occlusal surface is already open and exposed. Vasoconstrictors. A lot of times you will see doctors use anesthetic with a vasoconstrictor in it. The reason we use that is to slow down the intake of the anesthetic, and it helps increase the duration. So what that means is they'll stay numb longer, which is what we want. We want them to be numb throughout the whole process, so that way the doctor does not have to inject again. Some patients, the anesthetic will dissipate a lot faster through their system, and a lot of times they'll let you know if they've had that experience. So right before you place your topical in the patient's mouth, you want to ask them, have you had any adverse reactions to anesthetic before? Or just tell them, have you had anything negative happen when you were numb in the past at the dentist office? You want them to understand what we're talking about. There's a couple agents here that are listed, epinephrine, the levonorepinephrine, and the neocobiphrin. Those are all vasoconstrictors. Some of them are a little more friendly to not make your heart beat as fast, depending on which one we're using, and depending on the ratio of the vasoconstrictor, which is at the bottom here. It tells you how many whether it's 20,000 or 50,000 or 100,000, depending on the amount. You will see that on the side of the anesthetic along with the expiration date. If the patient has any sort of heart condition, or let's say they're pregnant, we want to use something that doesn't have a vasoconstrictor in it. The doctor will let you know what they want to use and what they're comfortable with. Other options for pain control in dentistry include inhalation sedation, which is nitrous oxide, otherwise known as laughing gas. In week 6, we will talk about nitrous oxide, and you guys will learn all of the symptoms that are related to it, which we will be looking for in our patients whenever it is administered. The doctor will be the one to administer this drug. We can set it up. We do not, however, turn it on. It is up to us to stay in the room with the patient and monitor them. So remember, when you have a patient on nitrous, you never leave them alone. You always stay in the room with them. So if you need to go somewhere and do something, you need someone else to come in and watch the patient for you. You need to remember that in your chart notes, you will be putting in there the duration of the nitrous, how much oxygen they had and how long, and all of the symptoms that the patient felt. Again, we will be going over this in week 6. Right now, we're just talking about it as another option for pain control. The great thing about nitrous is we can use it on all ages, and the patient can drive themselves, and once they are placed on oxygen for several minutes, they're completely sober again, and they can drive back home, and they're okay. This tells us that the patient inhales through a nose piece and feels the effect almost immediately. So it's pretty quick. The other great thing about nitrous is that if we have a change in our treatment plan, we can put them on oxygen, sober them up. When they come back, we can talk to them about the treatment plan changes within probably 5 to 6 minutes. And then if they decide, hey, you know what, I want to go ahead and have this tooth root canal because we've let them know it's going to need one, we can get it done that same day. Where the other two that are listed here, the anti-anxiety agents and the intravenous sedation, those are not a drug that we can take them off of easily. We have to wait for it to dissipate through the system and work its way out. So if a patient was on Valium or if a patient was IV sedated, we wouldn't be able to say, hey, I'm sorry, we can't save your tooth. The treatment plan has changed. You know, is it okay if we extract it? We don't expect them to understand what we're saying and to be able to make a conscious decision. So that's one great thing about nitrous is we can stop it, bring them back, have them, have a discussion with them on the treatment plan, and then they can make a decision that day if they want to move forward or if they want to reschedule and do it a different day. With the anti-anxiety agent like Valium, we always want to ask our patients to take it before, at least an hour or two before, and the doctor will give them instructions with that prescription. It's always best if they have someone drive them. Same with the IV sedation. This is considered a conscious sedation. If you work for an oral surgeon or a prosthodontist that does IV sedation, or possibly a general dentist, there are some general dentists that offer IV sedation for patients who have high anxiety and want to be IV sedated even to get any sort of treatment or their prophies done, and that's okay. You can be licensed by a doctor to help administer and place IVs. That is something that would be a different class. That is not something that we teach you in this course, but it is not something all dental assistants need. So it would really be based on the job that you have, depending on what you're doing every day. Isolation of teeth and moisture control. There's several materials that we can use to help isolate teeth. One of them that we use most commonly are cotton rolls. We are going to use cotton rolls pretty much for every procedure. So the reason we use the cotton roll is to keep the area dry, and another one is to help retract the tissues. The cotton roll will be a lifesaver when it comes to placing your suction in there because it will help retract the lip, help retract the tongue, and keep the patient safe from being scraped with the HVE, and also keep the area dry whenever we're placing any sort of materials in the mouth. A lot of the dental materials that we use require the area to be dry, which can be a little challenging considering we're working in a wet environment. When you're removing cotton rolls, please make sure to wet them first. Don't pull it off the oral mucosa if it's stuck. You want to wet it and then remove it. High volume evacuation. otherwise known as your HVE. This is what we use whenever we're doing any sort of restorative treatment. We use this to catch any tooth debris, water, suck up any saliva that's in there, so that way our patient isn't swallowing anything that they shouldn't be. These two pictures that you're looking at is working with a right-handed dentist. So while working with a right-handed dentist, you'll keep your suction in the right hand because you'll be passing with your left. This example here shows you on the upper right quadrant. You never want to cross over into the doctor's view. You'll always stay on the lingual side. What you want to remember is that the bevel tip will be facing the tooth, and you want it to be distal of the tooth being worked on. Everything is going to flow to the back of the mouth because they're laying down and gravity will pull it that way. It'll be easier for you if you can stay a little distal of where they're at. And you want it to be a little closer than that, kind of up against the tooth area, right next to it as close as you can get it, where the patient is still comfortable. Remember, do not cross over into the doctor's field of vision. On the upper left side, you'll be retracting the cheek and lip area, and you'll be on the buccal surface. This shows you if we were to be working on the mandible. On the lower right quadrant, you'll be retracting the tongue. It's a lot easier if you place a cotton roll down there first, because that will help protect the floor of the mouth and also retract that tongue area. On the lower left, you'll be retracting the lip and cheek. Again, if you place a cotton roll in there, it'll be a lot easier for you to place your suction without accidentally sucking up any soft tissue. Your air water syringe is going to be in your left hand at all times when we're doing any sort of restorative dentistry. And what I mean by restorative dentistry is we're prepping a tooth for a filling, we're prepping it for a crown or bridge or implant or anything like that. We want to have the HVE and the air water syringe in our hands at all times. So you'll be rinsing and drying a lot with your air water. Sometimes you can push both buttons at the same time if you kind of need to blast the tooth out if, rinsing it just isn't getting the job done, and that's okay. Or if you want to give the patient's mouth a really good rinse. You don't want them to close down on the HVE because it will regurgitate and spit back. I mean, it takes a good while for that to happen, but we also don't want them to get a hematoma in their mouth. So please don't let them close down on the HVE. It's not meant for that. If they do want to close down, you can always hand them the saliva ejector, and they'll let you know when they're ready to put it in their mouth. You can just pull out real quick, let them close on it if they're more comfortable that way. We want our patients to have the best possible experience, and we want them to be comfortable. So let them hold the saliva ejector if it makes them feel better and use it. Rubber dam is also a way for us to isolate teeth and to help with moisture control. What you see here is your rubber dam setup. The only thing missing from this picture looks like our bite block, but we do have a picture of it on our student portal, as well as a video on how to place it onto a typodont. Your patient will need to be numb whenever we're placing a rubber dam in there. And this shows you everything you need. So you have your rubber dam punch to punch a hole in the dam. You have your rubber dam forceps. These are also known as endo forceps because our endodontists place rubber dams every time they do a root canal. So just in case someone asks you for endo forceps and you're like, what? It's the same thing. We also have our rubber dam frame, our rubber dam, and the bite block is not in here. But we do have our ligature and our rubber dam clamps. These clamps that you see on the left side are all different sizes depending on the area that we're working on in the mouth, whether it be a molar, a premolar, or an anterior tooth. This is showing you the sequencing of placing the rubber dam. The ligature is a fancy word for floss. We want you to tie a piece of floss on that clamp because if it pops off, it's easier for us to retrieve it that way. You're going to use your rubber dam forceps to squeeze the clamp around the tooth. When you squeeze your forceps, it's going to spread it open for you. And you're going to place it right at the neck of the tooth. Be very careful not to impinge on the gingiva or you will pinch them. And they will not be happy with you later because it's going to hurt really bad. The next thing you want to do is stretch your rubber dam over the entire clamp. Make sure you pull this piece forward to completely invaginate it and it's sealed. We're not going to get any material underneath the rubber dam. You want to floss in between the teeth. And when you floss, you are going to push it down and pull the floss out. Please don't pop it up and down. Otherwise, going to pull the dam right back out of that interproximal space. The last thing you'll do is place the frame on here. What I want you to remember is that you're not puncturing the rubber dam with these little grabbers. You just want it to hold onto the dam. So it helps if you grab one side and stretch the other side out and then let it grab the material. If you puncture it, then it will probably rip. So you don't want to do that. Once it's placed, make sure your patient is nice and comfortable. They have a bite block in there to rest their jaw on because we don't want them to close down on the clamp itself. That could break the opposing tooth. This is a picture of an Instadam, and the reason it's called an Instadam is because they come with one hole in there ready to go. You don't have to puncture it, and it already has a frame on here. This would be great if we were doing a root canal. Let's say a patient with an emergency comes in and they have really bad pain in the tooth and they do need a root canal. The doctor will access it on the occlusal surface. So this is great for that because we don't need to access the other surfaces of the teeth. If we were placing a filling in this tooth, we would want it like the previous picture where we have our anchor tooth, which is where the clamp is, and then we have the other teeth exposed that we need to get to. So that way, if we're placing, let's say, a MOD, we can go ahead and put our restorative matrix band in there, and the clamp isn't in the way for us to get to all surfaces of the tooth. Patient, doctor, assistant positions during treatment. We want to make sure everyone's comfortable, right? We don't want to work all day and have our backs hurt or have, run into the doctor and bump heads and all these crazy things that can happen. So it's very important that we know where our dental instruments need to be and how close we need to be to the patient to make sure that, one, we're ergonomically correct and we're not hurting our backs all day, and also that we have a clear view and we can do our job correctly. So this is showing you that the assistant is always going to be a little higher than the doctor so we can see down into the mouth. Remember to put the light up pretty high so no one bangs their head on it. You want to be comfortable with that light. Also, this is showing you another view so you can see from this perspective of where the doctor will be and our dental assistant. Don't forget this little bar is going to go in front of you around your stomach so you can rest your elbows onto it or possibly lean on it if you need to. The transfer zone. So from 12 to 2, this is where your dental instruments will more than likely be unless you have a cart that moves around, then you can pretty much put it anywhere. But we want it in an area that is comfortable for the doctor and the dental assistant. The doctor needs to be able to move in their chair back and forth around here. So we generally don't put anything over here on this side unless they request it. The assistant zone, again, for you as well, you want this to be clear so you can move around and grab the instruments you need. The transfer zone is going to be from 4 to 7 if we're working with a right-handed doctor. The reason for that is because under no circumstances is it okay to pass an instrument over a patient's face. We don't want our patients to get injured. You need to remember also that they should be wearing eyewear. It's not okay for them to refuse the eyewear because then they're putting themselves at risk. So whether they have their own glasses on or our safety glasses, that's the only way we're following OSHA protocol. This is giving you an example of instruments you will be transferring to your dentist. We are going to learn all of these instruments today when you guys do the lecture in class. I want you to learn them before you leave today because you only have a couple more weeks to memorize them. So make it your duty to learn these while you're holding them in your hand and instrument transferring in the lab. Instrument transfer technique. While working with a right-handed dentist, you will be transferring with your left hand. This shows you a picture of exactly how it's going down. So if you're looking here, it says the assistant extends the pinky to grasp the doctor's instrument, holding the new instrument parallel to the old. This is so important that you remember this. One, it's your job and you'll have to do it. But two, when you go to the exam, I want you to remember that these instruments need to be parallel. Do you see how both doctor and assistant palms are facing up? Try to keep that in your mind. Your palm will always be facing up, and these instruments will flow naturally parallel. There's no flipping of the wrist. If you flip your wrist, you could run the risk of possibly snagging the patient or stabbing them with the instrument or the doctor, which is not our goal. Our goal is to make this as smooth as possible. You're going to be doing this a lot. So when you go to grab this instrument from your doctor, you're going to tuck it in, and it's going to go down this way, more towards your wrist, while you place this one in the hand of the doctor. You want to place this firmly so the doctor knows it's in their hand. They are not going to be looking at you, waiting for the instrument. Their hand will just be out there, waiting for you to place it in there. So when you place it in, make sure you place it firmly so the doctor feels it so they can grasp it. The other thing is you need to make sure you're on the opposite end of the instrument. If you hold it in the middle, that's called shorting the instrument, and the doctor doesn't have enough room to grab the instrument correctly. So make sure that you're holding it all the way on the end so they have plenty of room to grab it, and make sure that you do not flip your wrist. You can practice this at home. I would suggest that you practice this every single lab. This is something that a lot of our students, I think, take for granted and think, oh, it was really easy. I don't need to practice that. I want to go place another rubber dam, or I want to go take another x-ray. You need to practice all of these labs every single chance you get. This is an example of passing over the face. She's not following OSHA protocol. She does not have safety glasses on. There's a couple no-nos happening here. This is an example of shorting the instrument. The doctor is not able to grab it, and if they go to grab it and they're not looking, which they more than likely will not be looking, he or she could stab himself on this explorer. We don't want that to happen. So make sure that you're holding it all the way on the opposite side so they have plenty of room to grasp the instrument. Dental handpieces and their maintenance. It's important that we take care of all of our instruments, because when our instruments aren't working, it makes our job really hard. So let's make sure that we take care of them. All right, first we're going to talk about breaking down the treatment room. So the patient has come in, we sat them down, talked to them about their treatment, went over health history, got them numb. The doctor came in to anesthetize. We have already gone through instrument transfer. Now we need to break down the treatment room. This is just reminding you that each office will have a specific policy for cleaning and disinfecting the countertops and treatment areas. What you need to remember is that you will do it the same way for every single patient. And the reason I want you to remember that is because if you ever get asked, did you clean this room, or this room doesn't look really clean, it's only half cleaned, like we've taken the instruments out, but all of the barriers are still up and they look used. Those should never be questions asked by any of your coworkers. They should know when a room looks clean and when a room looks dirty still. So by getting in a habit of doing it the same way every time, you'll always know the answer. So you can say, this is what I did, this is how I clean the room. What I like to do is dispose of any plastic wrapping or anything that's not reusable. So what I do is I take the cover for the chair and I use that as my trash bag. Our trash cans in the rooms that we have aren't very big, and I don't like to fill it up because when the patient walks in, it doesn't look too, appeasing. It looks dirty and full and like it needs to be taken out. So I try to keep it clean in case they need to blow their nose or use it for anything personal. Try to think of that as more a patient trash can and not something that we're going to throw things into. If we do, let's try to cover it up so that way they don't see any gauze with, a little blood or anything like that on there. So take all of your disposables, put them in the bag that we use to cover the chair with. The other thing that's nice about doing this is if you ever have to go dumpster diving, which sometimes you do, you'll accidentally throw something away that you shouldn't have. You'll know that you can look in those bags as opposed to looking through the entire trash bag. Especially if the whole office has been using that trash can that's usually in the back. So let's remember to do that. Once you're done getting rid of all of your disposable items, the next thing I do is take my used needle and anesthetic carpule and put it in the sharps container. The only time the anesthetic carpules go into the sharps container is if they are not emptied. If they still have drugs in them, then they have to go in the sharps container. If the anesthetic carpule is completely empty, it is okay to throw it in the trash can. So get rid of your sharps, get rid of any sort of surgical blades or anything like that that you might have used. So that way when you take your instruments and you have them locked in their cassette, you can go through the hallway and know if I drop this or if someone runs into me, no one's going to get stabbed with a sharp or anything like that. It's completely safe. Before you leave, it's always nice if you want to spray your room real quick, go to sterilization, put your instruments in the sink so they can soak, or possibly in the sterilizer. If you're ready to go, you can go ahead and wipe them down, bag them, or wrap them, depending on how your office does that, and then start the autoclave immediately. We want to stay on top of our instruments and not let them get backed up. When you come back to the room, you will wipe everything down that you touched. So the dental unit, all of the instruments that were used. And what I mean by that is your suction, your HVE, your saliva ejector, your air water. Wipe down the chairs, the handles, and once your barriers have been removed from the light, you'll wipe down the light as well. Make sure you look at it and that it hasn't been sprayed with anything, because the next patient that lays down, the first thing they're going to look at is that light, right? Do not spray the light. It is electric. It is not okay to spray the light. The reason we place barriers on something like that is because it's considered a hard to clean surface. We don't place the barrier so that way we don't have to clean it. We place the barrier so that way when we wipe it down, it's easier for us to clean. It's not going in anyone's mouth, so we don't have to spray it, but we do need to at least wipe down the handles that were touched and all around it. Handpiece maintenance. These handpieces need to be sterilized after each patient use. Under no circumstances is it okay to reuse any of the handpieces that we use in restorative. So I'm talking about your high-speed handpiece and your friction grip slow speed. So those ones, whenever we let go of the rheostat, it has a negative pressure that pulls back into the chuck, and whatever's in the mouth, saliva, hemo, tooth debris, is being pulled in. Some offices will require that you put your handpieces in a statum for sterilization. Some offices might not have a statum and still use the autoclave. It's better if we use a statum because it's not as hard on them. They're not in there as long, so it's a little easier on the bearings. But it's important for us to oil them and for us to clean them. Some offices might have a cleaning machine, like in this picture here. What it does is we hook it up to the machine, close the lid, push the button, and it's going to push air and oil through the machine and push out anything that might have gotten stuck in there during the procedure. Then we're going to bag it and place it into the statum. This little guy down here is the statum. This is the autoclave. We want to put our handpieces into the statum to be sterilized. It takes a lot less time as well. So if we need these in the next hour before that patient comes in, we want to put them in the statum so that way they're ready to go. Usually only takes 10 to 15 minutes, depending on the setting we choose. Coronal polishing. Coronal polishing is something that dental assistants are allowed to do. We do not go subgingival. With this, it is not considered scaling teeth like hygienists do. Those are different instruments, and we will talk in detail about those on week 8 as well. For coronal polishing in today's lab, you guys will be polishing each other's teeth. If you want to start on Dexter first, you're more than welcome to get used to the rheostat and the speed of it before you guys start on each other, but I do want you to polish each other's teeth to get a feel for what it will be like. It's not something we do very commonly because we are on the doctor's side, which is mainly restorative, but it is something that we can do as dental assistants, so it's important that you learn this skill. What you see here is a hygiene handpiece. The hygiene handpiece can be used in between patients after being spray wipe sprayed because the end that goes on it, which is our prophy angle, which is this picture here, it's a rubber cup polisher. It's called a prophy angle. That is disposable. So we take that off and we spray wipe spray the handpiece and it's ready to go for the next patient. It's important that you use a fulcrum or a finger rest whenever you're polishing or using any instruments in the mouth. We don't want to accidentally slip and possibly hurt their gingiva or slice their oral mucosa. It's going to help you keep control of the instrument. So in this picture, you can see they have a fulcrum with their ring finger on the lower teeth. And in this picture, you can see they're using their pinky on this child's chin. So however you're comfortable, whichever finger works better for you, make sure that you have that finger rest so you stabilize your hand. Whenever we polish, a lot of our patients will ask us if this is going to whiten their teeth or remove any staining. Some extrinsic stains, which is down here at the bottom of this slide, it can remove, but the majority of those will need to be removed by scaling from the hygienist. In the endogenous stains, which are intrinsic stains, these are developmental. So when you're developing your teeth, a lot of times, depending on what you're exposed to, whether it be well water or an antibiotic your mother took while you were in her womb, or possibly overuse of fluoride, which can cause fluorodation, fluorosis in the teeth and little white spots in this picture here. These cannot be removed. This is something that was developed in the teeth when you were growing. So it's important that we know the difference so we can explain to the patient why the staining is not being removed. Prophy angles, there's many different types. Air polishing is not as commonly done in the patient's mouth anymore. We mainly use this in ortho to polish dentures or anything in the lab. Rubber cup polishing is very common. This is what we use in a regular polishing. The bristle brush is great if somebody has really bad staining or possibly ortho and their wire is still connected and you can't get in between those brackets. What you need to remember while using the bristle brush is it can be very abrasive. So do not, under any circumstances, touch their gingiva with the bristle brush because it will hurt them. Polishing agents, we can order prophy paste like this that comes, this is the commercial premix flavors, and it has fluoride in it and it's ready to go. If you have a patient who is allergic to fluoride, you will know because you will have read it on their health history as long as they put it down. You can also purchase commercial premixed without fluoride, or you can use the pumice powder. You just get a little in a dappen dish, wet it until it becomes a paste, and then you can use that to polish their teeth. What you need to remember is that this is a coarse. It's a lot more coarse than your toothpaste is. So while polishing the patient's teeth, you're not going to spend a lot of time on the tooth. You're going to move from either mesial to distal or distal to mesial, whatever is more comfortable for your hand, whatever feels more natural to you. And you're not going to spend a lot of time on the tooth because remember that prophy angle is going to be rotating depending on how hard you're pushing on the rheostat. You want to keep a steady pace and you don't want to push too hard and do it too quickly because you could possibly burn the tooth. Front office and interviewing skills. Front office responsibilities. Our front office patient coordinators and office managers will be up there supporting you guys in the practice. They will be greeting their patients, giving out new patient paperwork, answering the phones, checking the patients in and out, reviewing treatment plans and finances, scheduling and confirming appointments, verifying insurance. They do review health history with the patients as well if they have time. And then they do help explain post-op instructions. And this is a small list, really, of what they do, you guys. What I want you to remember is that this office is a team. Do not walk past that front office and ignore your patient when they walk in, expecting someone from the front office to do that job for you. That is your patient, right? How embarrassing would it be to not acknowledge them and then 5 minutes later you're going out there, "Hi, Sarah, are you ready for your appointment today?" And she's like, "Well, I just saw you." And you totally ignored me, right? That's not okay. You need to remember that we're trying to give the best possible patient experience. So when you see them walk in and your team's busy, or even if your team isn't busy, greet your patient. It will make the biggest difference for their experience because when they immediately walked in, they expect to be greeted. You do too. Whenever you're a patient, that's how you feel. So make sure you greet them. Tell them, "Hey, I'll be right with you," or "Hey, the front office will be right with you." And then maybe that'll let the front office ladies know or gentlemen know, "Hey, there's someone waiting," and they weren't sure because they were busy tied up with something else. Or if you've been trained and you know how to check someone in, go up there, greet them, check them in, review any notes that it has. "Hey, you know what? We need to see if you have any new insurance, or we have a question about a payment," or, help the team out. We need to work together because these are all of our patients. Customer patient service. What you guys need to remember is that it's so easy for them to go on social media or any of our websites and leave reviews. So you want to keep that in mind as well because we want them to leave with the best possible experience. Patients are going to get upset with us. It happens. None of us are perfect. Things happen and people get upset. But it's up to us to let them know we're doing everything we can to fix the situation. Try not to take things personally. It is not personal when they get upset about, fees or insurance or something that went wrong. Just let them know that you're doing your best and that you will get them an answer if you're not quite sure. Scheduling over the phone. You will be answering the phone when it rings up front. Please don't let it ring and feel like, oh, that's not my job because I'm a dental assistant. It is your job. It's important that we support each other. One thing you want to remember is to take notes. It's so easy to forget what the patient said right when you answer the phone. And then you're asking them how to spell their name or what their name is again, but they already told you that. That's usually not a good sign, and it doesn't make them feel like you're really paying attention. So take notes, ask them for a phone number in case you get disconnected, and then review what it is that they need. And if you follow up and explain to them exactly what they needed before they get off the phone, that phone call went well and that you guys solved whatever issue they were calling for, whether it be, I have pain and I need to come in and get seen, or I just have a question about my bill. That, before you let them off the phone, is there anything else I can do for you? Are you satisfied with what we did? Or ask them to get feedback. Common appointments in dentistry. You will need to know what these common appointments are. This might not be exactly what the office that you look for, what their schedule looks like, but it's important that you know. So when you get your job, again, make sure that you write these things down because it'll be a lot in the first week. It's a lot to remember. So write it down. Okay, an adult prophy, they usually want an hour, or they only want 50 minutes, or, however it goes. The doctor for a crown prep usually wants 90 minutes, or maybe you have a doctor who's a rock star and he can do it in 40 minutes, or, whatever the case may be. It's important because when you go to schedule this patient, you don't want to use 120 minutes when the doctor only wanted 30, and now we have a gap in the schedule and the patient's left. And they're going, well, who scheduled this person? And, someone else is calling to get in and we couldn't get them in because we scheduled incorrectly. So these are some things, just little details that we need to know as dental assistants when we're answering the phone and when we're working with our patients and scheduling them before they leave. Health history review. So we did talk a little bit about this in the beginning of the lecture. This is giving you an example of some questions to ask. You want to ask about pre-medication allergies, any medications that they're currently taking, ongoing treatment that they might be in, and any health concerns that they have. Verifying insurance. It's really important you understand what insurance your company accepts because that's one of the most common phone calls we get. They want to call, they want to make an appointment, but their first question is, what insurance do you accept, right? How embarrassing would it be if we had someone in the chair and we didn't accept their insurance, but we've already given them an exam, taken their x-rays, and now we're telling them, I'm so sorry, but we don't accept your insurance. That's a huge waste of everyone's time. Very embarrassing, not okay. So make sure you know that when you're answering the phone so you can give them correct answers and point them in the right direction. Predetermination form. It's important that you know what this form is because you will be using it a lot as a dental assistant. The majority of our patients are going to be asking what the fee for the service is, and a lot of times our insurance companies only give us an example of what it would be, and it's not 100%, okay, this is only going to cost you $200. So instead of giving them what we think it might cost, we can turn in a predetermination form to the insurance company, and they will tell us exactly what they're willing to cover and how much the fee will be. Sometimes it can take up to a month. If I were you, what I would do is put a little note in your calendar to follow up with the patient and with the insurance company to make sure that they receive the predetermination form and that it's being processed, because it can take so much time you might forget. And if we forget, then we won't reach back out to the patient and get them scheduled for that implant or possibly a night guard or whatever it was that they were hoping to get treatment done. HIPAA, you guys will learn and take a test on Health Insurance Portability and Accountability Act. No, we are not doing it in class, but you will do it once you get hired at your dental office. So what I want you to take away from this slide today is that HIPAA is there to protect our patients, that we don't accidentally share any personal any sort of patient information or health history or treatment plans or anything like that. They are not only talking about electronic documents, paper documents, but also our conversations and discussions. You need to remember when you guys go to lunch or go anywhere for that matter, it is not okay to talk about patients outside of this office. If you need to ask your doctor a question about one of the patients, that's okay. But it's not okay for us to go out to lunch at, McDonald's or whatever is next door and talk about our patients. One, they see you wearing scrubs, so it's pretty easy for them to assume you work at, one of these offices that's close by them. So if they see you doing that, do you think they're going to want to come to your office and be impatient when they can hear you chatting about others? No, that would not be okay. So keep that in mind, because HIPAA is there to make sure that, if something were to get reported because they heard you talking about a patient and they know who that is, you could be fined and, lose your job. So we don't want that to happen. We want to keep their health information private and secure, and we don't want to do that to our patients. It would not be good. Interviewing for success. Who is ready to go interviewing? I know you guys love interviewing. It's probably one of the harder things that we have to look forward to, but rest assured we are here to support you guys, and we're here to make sure that you're ready for your interview. So what I want you to remember is once you graduate, we are more than happy to have you come in and sit down with us and do some mock-up interviews, or we can do them now while you're in class. However you want to do it, let us know. To join our boot camp, you will be required to turn in your resume and do an interview with your instructor, whether it be over the phone or in person. So we are going to do get you in the groove of things before you have to go out there and do it. One thing that we've done for our students that's been very successful is they'll let us know what day they have an interview, and they'll come in an hour or 2 hours before, sit down with us, go over their instruments, shadow the team, do whatever it is that makes them feel most comfortable. Since they've graduated and haven't done a lab in a while, we want them to brush up on their skills before they go in so they feel comfortable. And it really helps them before they have to go in and do their interview to do that. Because remember, in dental assisting, we will be doing working interviews. So the doctor wants to see you work with their patients, work with their team. They want to see your skill set as well as your attitude. They are looking for people that have a good attitude and are willing to learn and be open and ask questions. So this is a little example of dental assistant tips, what to ask, all that good stuff. If you guys have any questions about this, please email your instructor or give me a call. I'm more than happy to talk to you about interviewing and give you some tips and help you guys rebuild your resume. Don't forget to ask questions about the employer, the company that you are applying for. One of the most frustrating things is when we sit down with an interviewee and, we kind of come to the end of it and we ask them if they have any questions for us and they say no. And that's very frustrating to us because we're sitting there thinking, well, why do you want to join our team if you don't know anything about us? Or I don't think you know anything about us, but maybe you do because you don't have any questions, right? So it's hard for us to get to know someone and try to get to know them if they're going to be a good person for this team when they're not asking us any questions or really not showing interest in the company itself. Another good thing to do in interviewing is take your resume with you, one for them and one for yourself. So that way when they ask you questions, you have it in front of you and you don't freeze up. I know it's easy to get nervous and, you forget your name, you forget everything. So it's nice if you keep your resume in front of you so you're ready to go and you can talk about your strengths and what kind of experience you bring to the table. Don't forget to thank them. Either send them a thank you email, send them a card that's handwritten. Something small like that can really go a long way and helps them remember who you are and why they want to hire you.